you guys hear me? Okay, good afternoon, everyone. Thanks so much for joining for today's briefing. It's really nice to see you guys in person. I also want to thank the entire team that's here for letting us kind of come in and readjusting your space today, and also for all the work you guys do every day. This is the monkeypox vaccination side of our house. On the other side is the COVID side. But I really appreciate everybody making the extra effort and all the work that this team does every day to improve access to vaccines. This is the Balboa Sports Complex, so I'm also grateful to the city of LA for letting us be here. It's the location of one of our 7 public health multi-service vaccination sites, and one of the many locations where people can receive the updated bivalent booster, which provides protection against the Omicron BA.5 subvariant. And this all started yesterday. I'm going to give you a quick update on the current status of the pandemic in LA County, SARS-CoV-2 variants, and the new bivalent booster and how to access it. My presentation will be followed by an update on monkeypox by Dr. Singhal, the Chief Medical Director for the LA County Department of Public Health. And I also want to note that Dr. Gounder is here as well. He's the Medical Director for respiratory diseases, and he'll join us to help answer some of the questions. The impact of the pandemic in LA County continues to decline. This past week, we've seen further significant decreases in reported cases, a decrease in hospital admissions, and a slight decrease in reported deaths. Our COVID-19 community level set by CDC remains in low for the second consecutive week. As a reminder, the COVID community level is based on 3 metrics as calculated by the CDC. The weekly case rate, which is now down to 159 reported cases per week per 100,000 people. The hospital admission rate, which is currently at 8 weekly admissions per 100,000 people, and the 7-day average of the proportion of staffed inpatient beds occupied by COVID-19 patients, which is now at 4.6%. Furthermore, all 8 of the COVID early alert signals in LA County indicate either low or medium levels of concern, with none reflecting high concern, and this obviously is posted on the dashboard. As of the week that ended August 20th, viral sequencing data for LA County indicates that the BA.5 subvariant of Omicron continues to dominate and accounts for 95% of sequenced specimens. The CDC has been reporting this increase in BA.4.6, that's a sublineage of the Omicron variant, across the country, especially in the Midwest, and they're estimating that 8.4% of sequenced specimens were BA.4.6 as of September 3rd. But you know, we've been tracking BA.4.6 for over a month now in LA County, and it remains at very low levels. It's been accounting for somewhere between 1% and 2% of our sequenced specimens per week since we first detected it back in July. For the week that ended August 20th, which is the most recent data available, BA.4.6 accounted for about 1.4% of our specimens. The encouraging trends in LA County in our COVID data translate to less risk for many residents and workers. However, because there's still elevated viral spread, we report on average about 1,900 cases a day. There are hundreds of thousands of residents who are more vulnerable for poor outcomes should they become infected. So slowing transmission to a weekly case rate of less than 100 per 100,000 people, dropping the number to about 1,400, remains an important goal for us as a county. We all help slow transmission when we get tested, if we have symptoms, or we're exposed, and when we stay home when we're sick. If you test positive, it's important to follow isolation requirements to avoid spreading to others. If you've been exposed to a known case and you're asymptomatic, It does remain important to wear a mask indoors when around others for 10 days after your last exposure, and to test 3 to 5 days after that exposure. As we're working to continue to slow transmission, everyone has an opportunity to maximize their defenses against serious illness and death. The arrival of this new updated bivalent booster that provides protection against the BA.5 subvariant of Omicron offers us a good opportunity to get up to date with our vaccine coverage. The new booster vaccines are called bivalent boosters because they provide dual protection against the original strain, the ancestral strain of SARS-CoV-2, and the BA.4 and BA.5 variants. And as I've said, 95% of what's circulating now is BA.5. Some have asked us about the safety of the new updated vaccines. We're all familiar with the annual updating of influenza vaccines every year. Scientists monitor flu strains around the world, and this data is used to inform how the annual vaccine should be updated. The same concept was used in updating the COVID booster to create this bivalent booster. Viral data from around the world was used to inform updates to the Pfizer and the Moderna COVID vaccines. At this point in the pandemic, there is extensive safety and effectiveness data on the mRNA vaccines, that's Pfizer and Moderna, and their effectiveness against COVID-19. For both of the new bivalent vaccines, a study on safety and effectiveness was performed earlier in the year on a very similar version of the vaccine that provided protection against the BA.1 subvariant instead of BA.4 and 5. As it became clear that the BA.5 subvariant was dominant, the bivalent boosters were updated to provide protection against BA.4 and BA.5, and further non-clinical safety studies were performed before they received their authorization. FDA carefully reviewed all of the available data on safety and efficacy and granted emergency use authorization for bivalent boosters from both Pfizer and Moderna on August 31st. CDC recommended the bivalent boosters on September 1st for individuals 12 and older, after a comprehensive scientific evaluation by the physicians, scientists, and epidemiology experts on the Advisory Committee on Immunization Practices. I just want to review briefly who is eligible to receive this new bivalent booster. Individuals who are 18 and older can receive either Moderna or the Pfizer bivalent booster, while children 12 to 17 can only receive the Pfizer bivalent booster. Both are given boosters for children under age 12 at some point in the near future. Note that the original Pfizer and Moderna vaccines can no longer be given as boosters for anyone aged 12 and older, and that the bivalent booster should be used instead. Pfizer's vaccine for children is still authorized as a booster for children ages 5 to 11. When we apply the eligibility criteria for the bivalent booster to the population in LA County, we see that this translates to 6.9 million vaccinated people eligible to receive the bivalent booster right now. Since the new booster directly targets the most dominant subvariant circulating at the moment, we're hopeful that by getting this bivalent booster, everyone eligible will be able to have greatly increased protection against the current strains of the virus, providing increased protection, as we know, against both severe disease and even getting infected in the first place. As we get deeper into the fall, we're going to encourage that everyone who is eligible to get their bivalent booster before the fall holiday season begins does so. We've survived 2 significant winter surges of this virus, but both have left a devastating impact on our community. The first occurred before the vaccine was widely available, and the second resulted from a highly infectious variant that did not fully match the virus that was circulating. The vaccine didn't match the virus that was circulating. We hope that with this new bivalent vaccine, we might reduce our chances of a third huge winter surge of COVID, since we have a pretty good match with what's circulating. During this initial week of bivalent boosters availability, we have more than 363,000 doses that are expected to arrive in LA County. More than 292,000 doses have already been received, and we expect another 71,000 doses later this week. We have a map here that you can see the over 1,500 sites across LA County that are prepared to administer the bivalent booster this week as they receive their doses. Over 700 of the sites are supported by public health, including 701 mobile vaccination teams, 7 multi-service vaccination sites like the one we're standing in today, and our 5 public health centers. The rest of the vaccination sites are in the community, at pharmacies, clinics, and other community service locations. Our priority remains to ensure that everyone has easy access to the bivalent booster. We remain especially focused on ensuring good access to these new boosters in the hardest hit communities, which you can see on this map in the areas that are shaded light green. You can search for places that offer the bivalent booster on our website, vaccinatedlacounty.com, and click on Find a Location. As always, you can also call our call center at 1-833-540-0473, 7 days a week, 8 in the morning till 8:30 at night, to get more information, if you have questions about the bivalent booster, or if you're just looking for a place to get vaccinated. And now I'm going to turn it over to Dr. Singhal to give an update on monkeypox, and after that, we'll go ahead and take your questions.
Good afternoon. I'm pleased to be here at our Balboa Sports Complex vaccination site to provide an update on monkeypox. Today's update will include a situational update, newly available data for persons treated with TPOX, an update on vaccine eligibility and distribution. I will also share guidance on what to do if you think you have been exposed to the monkeypox virus. I'll start with our customary situational update. Last week I shared that worldwide we surpassed 50,000 monkeypox cases. Since then, the number of cases of monkeypox reported worldwide has increased to 56,026 cases across over 100 countries. This includes over 21,000 confirmed cases in the United States. California continues to be the state reporting the largest number of cases in the United States, with 4,140 cases. As of today, there have been 1,694 cases of monkeypox identified in Los Angeles County, in addition to 92 cases reported in Long Beach and 22 cases reported in Pasadena. The profile of LA County cases continues to be consistent with what we are seeing nationally and globally. As we reported on our public data dashboard on September 2nd, the median age of monkeypox cases in LA County remains at 35 years. 98% of monkeypox cases report being male, and 95% of cases where sexual orientation is known report being LGBTQ+. Latinx and white residents continue to account for the largest proportion of cases, with 42% and 28% of monkeypox cases found in these populations respectively. Service Planning Area 4, which is our metro SPA, continues to have the largest proportion of cases at 45%, followed by 15% of cases living in SPA 2, which covers our San Fernando and Santa Clarita valleys. We are currently investigating a death of a person with monkeypox in Los Angeles County. We are early in the investigation and do not have additional details available at this time. As soon as details become available, we will share them while maintaining confidentiality and privacy. This is one of 2 deaths in the United States that are currently under investigation to determine whether monkeypox was a contributing cause of death. Across the world, there have been 7 confirmed deaths among monkeypox cases in non-endemic countries. Now I will provide an update on our county's trend of new monkeypox cases since the start of the outbreak. On the poster, you will see the latest epidemiological or epi curve for monkeypox cases in LA County by episode date or when case reports onset of symptoms. The columns show weekly case numbers beginning in mid-May through last week. After increasing in the months of June and July, over the month of August, our weekly new case numbers remained relatively steady, beginning with 241 new cases during the week of August 6th to 204 new cases in the week ending August 27th. Due to a lag in reporting, data is incomplete for last week. In addition, although in mid-July, monkeypox cases were doubling in as few as 8 days, our doubling time has now increased to 29 days. Both the plateauing of new weekly cases and the increasing doubling time continue to support that monkeypox virus transmission is slowing in LA County. Next, I'll touch on vaccination efforts. We'll start with an update on our vaccine supply and doses administered. We are currently in tranche 1 of phase 4 of vaccine distribution. To date, we have received about 57,000 vials of the Jynneos vaccine, which we estimate equates to about 113,000 doses. As of today, 42,948 vials and 61,664 doses of the Jynneos vaccine have been administered. This represents 75% of the total vials received and 54% of total doses received. Of doses administered, approximately 51,000 or 84% are first doses and about 10,000 or 16% are second doses. At this time, only about 1/3 of individuals in LA County who are due for a second dose of monkeypox vaccine have received it. We are strongly encouraging that anyone who is due should receive their second dose to optimize their immune response. We also want to announce today that our eligibility criteria for the monkeypox vaccine is being updated. Given that we have adequate vaccine supplies, we are expanding eligibility to include not only those who are at high risk and may have had a recent exposure, but those who may be at risk for future exposures. Starting today, monkeypox vaccine is now available to residents who self-attest to being in any of the following groups: gay or bisexual men or any men or transgender people who have sex with men or transgender people, persons of any gender, sexual orientation who engage in commercial or transactional sex, persons living with HIV, especially persons with uncontrolled or advanced HIV disease, persons who had skin-to-skin or intimate contact with someone with suspected or confirmed monkeypox, including those who have not yet been confirmed by public health. Residents who meet prior eligibility criteria, which are listed on our monkeypox webpage, remain eligible for vaccination, and we continue to prioritize residents who are immunocompromised since they may be at high risk for severe disease. As a reminder, residents who are eligible for a first dose or due for their second dose can get vaccinated through several routes. They can reach out to their regular healthcare provider and ask if they are offering monkeypox vaccine. Residents can also get vaccinated through public vaccination sites. A list of vaccination sites, including sites offering walk-up, can be found on the public health webpage at ph.lacounty.gov/monkeypox. Residents who prefer to make an appointment can go to myturn.ca.gov to find a nearby community or provider site that is vaccinating. With vaccine supplies continuing to improve and additional vaccination clinics being added, we strongly recommend eligible residents to walk up or schedule an appointment to get vaccinated. We'll now move on to TPOXX. So we now have preliminary demographic and clinical data describing key characteristics of residents who have received tecovirimat or TPOXX treatment in LA County. The data I am sharing today is for a sample of 311 patients, so it does not represent all residents who have received TPOXX treatment to date. Based on this sample, the median age of residents who received TPOXX treatment is 36 years, and 96% of treated patients identified as male. Latinx residents, followed by white residents, accounted for the largest proportion of patients receiving treatment, representing 37% and 33% respectively of all patients treated. In addition, 16% were Black or African American and 5% were Asian. Most patients receiving TPOXX, about 93%, were treated in outpatient settings. The most common indications for treatment were lesions in sensitive areas and severe pain. Over 1/4 of patients who received TPOXX were immunocompromised, and half of patients were HIV positive. Starting tomorrow, this TPOXX data will be posted each Friday as part of our Monkeypox data dashboard on our public health Monkeypox webpage. Finally, I'd like to share guidance for residents who have been exposed to someone with monkeypox. If you've been exposed and do not have symptoms such as a rash or flu-like symptoms, please get vaccinated as soon as possible. This can prevent you from becoming infected with the monkeypox virus. If you've been exposed, it is best to get vaccinated within 4 days of exposure, but you can be vaccinated up to 14 days after exposure. If you develop monkeypox symptoms, the monkeypox vaccine is no longer indicated. Instead, see a healthcare provider right away to get tested and evaluated for TPOXX treatment. For the medical visit, please cover your rash and wear a well-fitting mask. If you don't have a provider or health insurance, call the Public Health Call Center at 833-540-0473 between the hours of 8 a.m. and 8:30 p.m. daily. As you wait for your monkeypox results, follow the monkeypox isolation instructions that are posted on our monkeypox webpage. Instructions include staying at home, keeping the rash covered, and not having any close contact, including sharing items with others and pets. Additional details are available in multiple languages on our Monkeypox webpage, and residents with questions can also call our Public Health Call Center. Thank you very much.
We're going to go ahead and take questions. Brett's back there with the mic to make sure we get to everyone's questions.
Any questions?
Hi, Dr. Ferrer. It's nice to see you in person. Thank you for holding this in-person briefing. Before I ask my questions, I just want to know what's the parameters in terms of, do I get 1, 2, 3 questions? I have a couple for Dr. Singhal and a couple for, okay. Well, obviously very sorry to hear about the one confirmed monkeypox death, Dr. Singhal. Will this change the response strategy moving forward? And do we know if this person had underlying conditions?
So I do want to confirm first that it's not a confirmed death due to monkeypox. So we do have a death of a person who did have a diagnosis of monkeypox. And so this is something that we will investigate further. Part of the investigation will be working with CDC and with the state to determine if there is any changes that are needed in the guidelines that they have put out regarding how we treat persons with monkeypox, especially if they're getting severely ill. That's what I can share now.
Okay, and do we know how long that will take?
It is variable. We will be doing an autopsy, so it does take time for those results to come back. So it may be as soon as a few days, or it may take a few weeks.
And in terms of strategy moving forward?
Same thing. I think it's once we have more information, then we can talk about strategy.
Okay, very good. Thank you so much. All right, Dr. Ferrer, last week I asked you about the hundreds of parents who submitted their names to the LA County Board of Supervisors. Now, obviously, we have the superintendent's list that is growing as of this morning, 27. I just want to get your response to their wish that you would align with the state and as it relates to the close contact mask policy. Why not align with the state? And really, Pasadena Health Department, Long Beach Health Department, they align with the state.
Yeah, it's a really good question. Thanks a lot, Marla. And I know we've been talking with the superintendent as well as other, the labor unions, the parents, and students at the schools. You know, I want to just note a couple of things because I think there are some places where there's some misinformation about the rules at the schools. This is not a rule for the schools. The quarantine and isolation guidance are the same for everyone across the whole county. So everyone is asked to go ahead and wear that mask if you've been exposed for 10 days after the exposure. Everyone's asked to get a test between days 3 and 5. And everyone's asked if they develop symptoms to please go isolate at home, get that test done to make sure that you're not in fact infected. This decision to go ahead and ask people to take these steps after an exposure do actually align fully with CDC and with CDPH, the State Department of Public Health, in terms of their guidance. So everybody agrees that the most efficacious steps that we should all take to protect each other if we have an exposure is, in fact, to go ahead, put that mask on, and put that mask on immediately after you've had the exposure. And the reason for that is, especially now with Omicron, highly infectious variant, people are actually capable of infecting others 2 days before they show any signs or symptoms of illness themselves. And many people, as we know, don't actually show any signs of illness, but are still capable of infecting others. So when you have a highly infectious variant, and we can put that in context, there's a team that reported to us earlier in the week. They had one known case amongst team members. On day 2, they had 4 cases, and by day 5, they had over 25 cases, including both of the coaches. That's what I'm talking about when I say highly infectious variant. Spreads very easily from people who are in close contact with others. That's why the CDC guidance, the state guidance, and ours all say important to put a mask on after you've had the exposure. I think where folks are finding a problem is that we actually use the health officer authority to require that people take those steps. It's similar to the authority that Cal OSHA uses for workplaces. So workers who have had an exposure at a workplace are also required, if they remain at work during that 10-day period, to go ahead and put a mask on. So regulatory agencies, I think, again, align by going ahead and issuing the regulations that create as much safety as possible. And I think that's what we've done, and that's what the state expects us to do. The state issues that guidance with the sense that some local jurisdictions will go ahead and use that guidance in health officer orders. We hear the concern that's raised about how, in fact, we're going to administer this, in particularly in some of the larger schools, but we do think, particularly with the data coming in from the schools, that shows a fair number of outbreaks, lots of clusters of cases, that while transmission is still elevated, good idea for everyone to have to go ahead when they're indoors to put on those masks. So I hope that answers it.
Certainly, and you know, it's also noted, and this is a good thing, of course, that BA.5 is causing less severe disease, and certainly its predecessors, without question. When we're talking about a student body of 175,000 and 300,000 parents who want the choice for their child, why not give them that choice?
I mean, I think that's always the issue for public health, and I think for all of us as a society. We don't let people choose whether or not they want to wear seatbelts. We don't let people choose whether or not they're going to smoke tobacco products in spaces where other people are, because we've decided that the risk of those activities for our collective good is worth asking people to engage in protective behaviors collectively. I think we made the same decision. I mean, I presented a couple of weeks ago the mortality data on COVID. This is still not sort of a very innocuous disease. There are still steps we should all take to protect each other, particularly the most vulnerable. And one of those steps is, if you know you had an exposure to a highly infectious disease that's capable still of causing severe illness, go ahead, put that mask on, please.
Last question, or it may not be my last question. The 1,900 cases a day that you mentioned, and then you mentioned our goal is to get down to 1,400 cases a day. Okay, so
that's the goal.
We've dropped since mid-July. We've been dropping. This is without the universal indoor mask mandate. Again, I want to ask you, what is contributing to this continual decline despite the universal mask mandate? And if we do hit the 1,400 cases a day, will that make you reconsider your
Yeah.
mask directive for the close contact policy?
Yeah, it's a great question. I mean, I think a lot of factors contribute to the decline. Obviously, an important factor is that we don't have a new variant that we haven't seen before that's circulating in large numbers, that's capable of reinfecting all of us, even if we've been recently infected, and is capable of evading some of the vaccine protections. So I think that contributes. I think our high rate of vaccination, over 80% of folks 5 and older in LA County fully vaccinated. While we still need to make sure people are getting updates with the boosters, we have a level of protection that, as you noted, is really helps. And even though that level of vaccine protection against transmission has waned over time, people who are unvaccinated are still 2 times more likely to get infected than people who are vaccinated. So we still have protections even against getting infected. I will also say that everywhere I go, there are people being very cautious. I will also note that when you go into a healthcare facility, not a single person questions why we're putting a mask on. None of you said, oh, why would I put my mask on in here? Because we all know that this is a place where there may be some people who are vulnerable, and we want to keep our workforce safe, and so we all have no problem putting our masks on. I would ask that people do the same on public transit. We have data that shows that public transit workers have 1.5 times elevated risk of mortality. Again, those are places where the data says higher risk setting, please put your masks on. And I think that's what we've been trying to do, encourage people, protect each other. There's still lots of vulnerable people. We still have a lot of transmission that's happening. So yes, people should keep their masks on when they're indoors. It's a strong recommendation in almost every site except for the higher risk sites where people are, like here, required to put a mask on. I think your question also talks about, sort of the role we play in using what we know about the science to guide our recommendations. The recommendations on indoor masking are really tied to the community levels of transmission, and we've already published our document that says when we get below 100 new cases a week, it'll be no longer strongly recommended for everybody. It will be a strong recommendation for vulnerable people, and then it will be an individual choice in terms of what public health advises around indoor masking. But that's very different than why we require people to wear masks around the traditional quarantine period after an exposure. We ask people to wear masks after an exposure because given how infectious this variant is, you have a pretty decent likelihood of getting infected and passing that infection on to others before you know you're infected. So that science hasn't changed. The science around the incubation period hasn't changed. So I think it's likely we'll continue to ask people to go ahead and wear that mask after they've had an exposure, and it won't be tied to the level of transmission. It may be tied to other information that we get that reduces people's risk even more than it's reduced now, but it wouldn't really be tied to transmission because it's about what to do if you've had an exposure.
We have several questions from Ron Lynn from the LA Times. Regarding the LA Taco story on more than 2,000 people getting improperly diluted vaccine, can you tell us why the department didn't disclose it publicly, that as soon as it was aware of it, and you'll make disclosures of those errors public in the future?
Yeah, thanks, Ron. I think the issue on a public disclosure on our part was that we were just interested in making sure that at the site where vaccines were being administered, that corrective actions had been taken. Remember, this is months after, this is found in an audit, so it was months after the actual events had taken place. So we were very interested at that point in making sure that at the site, corrective actions had been taken, those problems were very unlikely to be repeated, and that notification of any patients had happened. Our sense was to work with the provider on making sure that the appropriate steps to remedy the situation were taken and were happening. didn't really require us as the health department. It's not one of our sites. It's not a site we manage or run. Didn't really require us to immediately notify. I do think there was press at the time, Ron, on that issue, and we did issue a statement clarifying the work that we had done with the provider, but I don't think it was a situation where we would automatically be notifying folks that far after an event had happened. I think if something happens today and we're notified about a problem today, it makes a lot more sense for us to use the media and all of you to help us get information out. But already that was many, many months after the diluted vaccines had been administered. And again, I want to note that as large as that number is, over 20 million doses of vaccine have been administered in LA County. So I want to really thank everybody who works on vaccine administration. Super rare event for there to be a problem with the administration. So, I want to acknowledge and thank the providers doing their very best. This was an unfortunate incident, and I feel like La Clínica really took a lot of steps very aggressively to try to make sure this can never happen again.
Just two more questions from Ron. There has been some concern about the potential for vaccination errors because the vaccine vial caps for the new booster are similar to some of the old shots, which are still being used for people getting vaccinated for the first time. What's being done to avoid giving people the conventional vaccines when they want the updated booster? And will the new booster also protect against BA.4.6?
Yeah, let me ask the last question. I think because the construction of the new booster doses really use strains from BA.4 and BA.5, there's a lot of hope that it will work against BA.4.6. And again, we'll have to see that evidence as time progresses. In terms of sort of the steps that folks take, one is I want to note all vaccinators are connected to us and they all receive our instructions and a lot of technical assistance from us to avoid those kinds of errors. In our own, sort of places where we're administering, we do a lot of control on that, including that there are designated tables where people go depending on the type of vaccine that they're receiving. And I think that's a common practice. I don't know if Kristen is still here, but Kristen, I don't know if you want to just elaborate at all, like for a second, on sort of how we do our training and the practices we use so there can be no mix-up in which dose goes to which person. I think it's important for folks to know we do monkeypox here, we do COVID somewhere else, and we also, once we start vaccinating for flu, we'll be offering flu here. So it's a good question because you absolutely have to make sure people are getting what they came in for. But we have a whole team that works on the logistics and operations side to make sure that there's no mix-up. Is there something to Kristen Mundy.
Hi, good afternoon. So we've, anytime we have multiple products, of course, that's a concern for us to make sure that the clients are getting the vaccine that they came here for. So we've logistically, separated monkeypox as well as COVID vaccines. But even within COVID, there's multiple COVID vaccines. So we color code all of our products to make sure that, the right COVID vaccine is going to the appropriate client.
Kristen, can you say and spell your name for the media?
I'm sorry?
Say and spell your name.
Oh, my name. Sorry, Kristen Mundy, CRISTINMONDY, and I'm the Regional Health Officer for SPA 3 and SPA 4.
And I think Marla has a few follow-ups.
I do. Okay, so getting back to the 10-day close contact mask, just so I'm clear, we hear a lot of people say that we are in the endemic phase. Do you think that we are in the endemic phase? And if we are, indefinitely the mask mandate as it relates to close contacts will stay?
Well, I think for me, whether we call it the endemic phase or a new phase, may be irrelevant. I think what we all acknowledge is we've got a lot of really good tools at our hands that make it very appropriate for us to be changing up the response. I think in terms of when we might feel more comfortable not asking people to take measures to really protect others when they've been exposed is when we feel like we really are at a place where mortality rates are super low from COVID, and that morbidity is not as big a problem either. You know, sometimes I know it's hard to hear, but as public health folks, we're going to always be, I think, a little bit more cautious because it's still a relatively new disease. I want to note that we don't really understand fully the impact on long COVID. We don't understand fully the impact on people's health from repeat infections. And the idea that you're wearing a mask when you've had an exposure to a highly infectious variant, that we really need to learn more about the long-term impact. So we're going to protect people where we can from getting infected. I think it's just sensible, and because it's wearing a mask. I think if it was a very disruptive measure that we were trying to introduce, it would be a lot harder to ask people to do something.
I think the parents would say that it is.
You know, again, some parents would say that. I've been very clear that other parents would like us, frankly, to be more aggressive. There are many schools where when you go to those schools, most of the children are still wearing masks. I think our labor union partners are an important voice as well, because they're working in these environments every single day and working really hard. So I think it is a community where there are diverse perspectives. As public health practitioners, we really try to align with the science.
Last question.
Last question. Okay, hold on. I had a few. I'm gonna combine two then. Okay. So, I mean, the in-person is great because then we can ask follow-ups. Will this become a regular? Is this the new Thursday, 1 o'clock? Oh no, I have to see Marla again in person. And then I will ask about disabling social media comments for those people who say this further erodes trust in you and the health department. Why not just turn them back on in the name of transparency?
Yeah. So, you know, I had indicated, you know, we are planning to return to in-person briefings. I'm not sure they'll be every week. You know, it really depends on the trajectory of the pandemic. Today we're really doing this because we want people to know how easy it is to access bivalent vaccines and that we're open for business for people who need to get vaccinated. We're hoping, as you know, we're happy to take you to the side where we're actually doing the COVID vaccine so you can let people know it's really important that they know that access is here and vaccines are here. But Brett is working really hard to find us a location where we will always have whatever cadence we have the briefings, that we will be back to in-person briefings. We welcome that as well. We think we do better when we're able to talk with people directly. So we'll be very pleased. We are cognizant that people still want us to have slides, and so the technology side of it is what we're really working on, and that some people want to be able to join virtually. So I think Brett and his team are working super hard to make that happen. So I think, you know, you should expect that, you know, in the next few weeks we're going to definitely transition to that. So. And the social media element? Oh, you know, I want to note, I checked, actually, I asked Brett to send me a list this morning of sort of what happens when people contact us with their questions. You know, how well do we do responding on all of the different platforms? So everyone is still, I want to really clear this up. All of our platforms allow for people to ask us questions and for them to get answers. And I think of all the folks that came in this week, there's only answers pending for 2 folks. So people using those social media platforms to ask us questions and get answers from us, there's still, you know, accessibility for everyone for that, and that's a good role for us to play. I think what you're asking us to do is a very different role, is to be a platform where individual people can exchange their ideas with each other about COVID or monkeypox, whatever issue it is that they're interested in. And because of our experience of our sites ending up being megaphones for misinformation, we decided that wasn't actually a helpful role for us. And we know that there are so many platforms where people can exchange that information with each other. We're not shutting down people's ability to talk to each other about what they like or don't like with social media. We're not shutting down anybody's access to express their views to us and get a response from us. What we weren't allowing for is the continued use of our platforms to spread a lot of misinformation. And in some cases, as people have noted, there was a fair amount of hate that was also circulating. But that's just not our job, Marla, to be honest.
Thank you, everybody.
Thank you. Okay, thanks everyone. Nice to see you.